Daktari A Quick One, karibuni tena to yet another one of these amazing episodes of Daktari A Quick One. And today's show is a bit, out of the ordinary. Kwanza leo ni vita kati ya mandugu. Hii vita nataka to address. We must live in harmony in this profession. Sisi sote tupendane, tukae pamoja kindugu. So today, we address a very sensitive topic. I will try and be as sensitive as possible to my guest, and he will try and be as sensitive as possible to me. To maintain decorum. No? Okay? So it's a clinical officer, and today we are doing a clinical officer on Daktari A Quick One. Tupate kujua hii mambo ilianza wapi, inaenda wapi, mbona tunapigana. Okay? Weather is chilly, 75th of January, but tutamudu regardless. So my guest today is one very amazing guy hapa. Tumejuana for quite some time. His name is Daniel. Not Dan.
Daniel Mumo.
Amazing. So me and Daniel are going to give you an amazing show. Stay tuned. Kama kawaida, like, comment, share hapo chini. Okay? If you have any opinions, let me know. Sisi hatuogopi opinions. So bring it on. Daktari A Quick One. See you in there. Hello. Karibuni tena wadau. Yet another one of these amazing episodes of Daktari A Quick One. Na leo, as I told you, it's a very interesting show because we have an interesting guy from an interesting line of medicine that we want to explore. Hii imekuwa controversial for some people, straightforward for some people, but today we want to demystify some things and, put the records saturate. Okay, so karibuni sana. Kama piga like, subscription and share. Today we have Dan Kialo. Karibu.
Asante sana.
Is it Kialo?
Yes, it's Kialo. But
is it or Chalo?
Mbona umeavoid Mumo?
Oh, you're Mumo as well.
Yeah.
My favorite Kamba name is Mo. Just Mo.
Okay, yeah.
Followed by
Mumo.
Followed by Chalo. I always feel it should be Kialo, but you say it's
Chalo. Sasa unajua shida wewe si Mkamba.
Mimi ni Mkamba. Matindata.
Next.
Anyway, karibu sana.
Asante sana.
I always give my guests the pleasure of introducing themselves, of identifying the way they want to identify. So, Tupe, who are you? Would you like us to know you?
You're in the season of not identifying as anything else. Anyway.
What do you identify as? You should identify.
The plant. My name is Daniel Mumo. I am a clinical officer. And it's a pleasure to be on this, about to say show, but podcast. I think I've actually been following your episodes from the first episode.
Vile inafaa, fan numero uno.
Yeah. And some good work, I say. I identify with so much of the conversations right here, and it's quite a very, very good learning platform. And so I also look forward to speaking to someone. Maybe today there's someone who's just finished from 4 the other day. They're like, I'm looking at doing something, and they're like, clinical medicine, what do they do? What does it mean? And
exactly. I also don't know what it means, so I hope to learn from you.
Kanchit can die.
Kanchit can die. Kuna vitu sielewangi in this thing, and that's why I think this show is very timely, especially now that people are actually going to university and colleges. Yeah? So it's important to put some of this info out there.
Right, sure.
So I'm humble. I'm happy that you're here. Karibu sana.
Asante sana. I would say I am equally humbled as well to be here.
Karibu.
I think I'm coming one guest after Stanley Ariaro.
Two. There's two other. Actually, 3 episodes.
But
just tell us now, for this young person who's finished their Form 4, anatafuta career. Unajua it's usually a very red, gray area.
Yeah, that's true.
You're not sure what to do.
What do you want to do?
Unaangalia hii pia ni mzuri. Hii nani anakuambia Kemuto alifanya hiyo hajawahi pata kazi sasa ni 10 years. Ukamwambia my cousin. So like what do you think? Is it a path to consider?
That's clinical medicine. Yeah, definitely, because I did it. I mean, but
do you have any regrets?
Is this girl who says my school didn't pay me to advertise, so I'm also not paid to advertise. Anyway, so for clinical medicine is it's just like a career kama ile ingine. But one thing I know, and I think this I will say to anyone else when if I met who is any career path is still a career path. Let me start with that, because and you might need to be taking notes. Anyway, I have seen people who've done accounting, for example, something that mimi na maths, but you look at their career trajectory and you're like, manze, ama ningefanya hii kitu. And then someone who's done some funny social study thing uko, like I have a friend who did something in that at St. Paul's University, St. Paul's University,
University
SPU.
of choice.
Yes, so there. And in the beginning I think nilikuwa tu sasa hii course
we na waste time.
Sinijudge, but you look at what they after their campus life nini, and they take on a very good forget about they came from what family, and so I feel like every career trajectory is worth it, including arts. Like kuna mtu tu yeye nilina kufanya sijui kupika sijui, and they end up being
they forge a path for themselves. Exactly. And they do right.
There are people who are doing bespoke tailors, what I think that was trending some time ago. And alienda tu tailoring hapa tu mkimuona, in fact 6 months down the line ashamaliza, wewe bado uko anatomy.
So what are the qualifications for becoming a clinical officer?
Yes, so for clinical medicine, we have only diploma and the degree choices. So for the degree choices, depends where you want to.
So first of all, tuambie diploma, how long has it been there before we come to this degree? That I think is younger,
points
right?
To the direction, the degree
diploma has always been there, right?
Yeah, diploma has always been there.
And KMTC. Right?
Yeah, but
it started in KMTC, or if I'm not wrong.
Could be,
that's
but I don't really know the when KMTC started. But the training of medicine generally should have started in the in the colonial periods. But it started shaping out in around 1980s, and earlier than that, we actually already had diploma in clinical medicine. Very remarkably, Uganda or the Kampala International University is very, 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 how do they say, remarkable. Ukianza kwa history ya clinical medicine, even the transitioning in around 2003 there about to the degree option, they were the pioneers there. Unfortunately, they scrapped the degree qualifications from their market. Sasa wabaki na diploma, I believe.
Or they started the degree, then later on scrap it off.
They were the first to train. Yes, but then now, of course, so Kenya also adopted it initially as a 3-year curriculum, then later on the degree choice now to a 4-year, transitioned it to a 4-year curriculum, and then the diploma to a 3-year curriculum.
But the diploma has always been 3 years, right?
Earlier on, it should have been less because the degree was 3. When it was the curriculum was starting.
Before there was a degree diploma, it was less, like 2.5,
maybe something like that. But
you need to ask your seniors.
Na wengine wananisikiza hapa kijana anasema but given that the degree curriculum was 3 years, so definitely maybe the diploma was maybe 2.5 or 2 with now and then you go for the experience or something. But now it's set out for 3 and 4. So what are you asking now, the curriculum or something?
I was asking like qualification ya kuingia diploma, then kuingia degree. Then you tell us about how the curriculum is.
So entry, subject clusters. niongea haraka. So subject clusters, being it's a science, it has a leaning on science. So the math stroke physics.
You need to pass those. You need to get a what? A B, a C, a D?
Yes. So
an E?
Depending with
to do them.
depending with where you're taking it from, the clusters are also always different. If you wanted to take it from, say, for example, anyway, the clusters are always different for whatever program that is here. So anyway, I know of a university that would take 38 for government entry. So that's the lowest I've actually come across. Yes,
that's for degree.
Yes, and anyway, I'm not paid to advertise, but that's Uzima University.
Oh, Uzima.
Yes, I actually went to Uzima. Shout outs. Nini watu wa finance mnaona hii
wakutumia kitu wakipata influx
kuna clients kuna students wameongezeka
wajue ni wewe kazi ya mdomo yako.
So what I saying, so yeah, and
so 38 as a cluster,
and that's for the degree option. So for
and
that
then it takes 4 years.
So so for the you definitely need to have passed math stroke physics. The languages are always English stroke Kiswahili, mathematics,
maths and physics, biology, chemistry,
stroke chemistry, maths stroke, and what was that other thing? They're supposed to be 4 subjects.
So we have maths. So these are stroke me. Unajua mimi nilikuwa high school kitambo. I remember. So maths stroke physics means either or. Or both.
When you're calculating the class, should be maths, English stroke Swahili, biology and chemistry independent. Should be, yes, because they should be taking 2 sciences.
Are very important.
So for that one, now your calculations should end up at 38 for the 4. Then generally, the entry point, hata ukicalculate, by the time una have 38 kwa hiyo, lazima utakuwa na kitu kaa B. Unless kama umeamka hizo zingine sana uko na C+, but I believe just like any other, the cut-off point is C+. You can go for it.
Nowadays, you can do nowadays C+. You can join
via KUCCPS. Yes, but then your cluster I believe is the most important thing. Kenya mpata generally taka ni A na for some reason hujafikisha hizi anyway haiwezekani. So that's for it. For diploma,
so a B with a cluster of 38.
Yeah, the cluster of 38. For diploma, the same cluster subjects.
I think it's a C.
C minus. Because what you calculate, their clusters are much way lower. Yes, but a C should be overall should be able to calculate into the clusters for say for example for chemistry.
We will go check.
KCCPS, by the way, it keep changing.
So now let's come to now the training. So degree, because I know diploma students, I see them in the word from the word go. First year clinical medicine.
Wanafanya nini huko? Munaenda wapi? Okay.
I don't know. But I see students from clinical medicine.
Okay.
Degree, I see them at internship. Is it true?
Wenda huko. Okay. cut that point. Ile kutoa kitu. So no.
How is the curriculum?
So the curriculum for,
because you did that degree. So tell us what you know.
I mean, I know both.
You know both? Okay,
because I've also been involved in training yao ingine. Sasa, so for the degree, for the degree option, I think it would be important to say that commonly, diploma is called Diploma Clinical Medicine and Surgery. Commonly, ama how it should be by the MOH structure, kitu kama hiyo, yes, and surgery. And then for the degree option, it should be ideally, and that's why it's actually BSCC when you go for your internship. So it's bachelor's, whatever, science, clinical medicine, and community health. Yes, so it should be in community health. So it has so much leaning into primary health, the degree option, and so it also goes so much into management rather than the diploma option, which is so much of the clinical. I would call the diploma as a stepping point into clinical practice. Then maybe if someone wants to go higher, because even in the scheme of the scope of practice for clinical officers, you realize there are job groups you can never go past with a diploma, even if you had 17 years of experience, unless you're so corrupt. Yeah, of course. Yes, but I believe you can't actually go past job group L.
Oh, okay.
Yes,
okay.
Without a degree. Now ukifika hapo, that should be senior clinical officer. So they start off at H as a
but then
diploma.
They can also do what's called higher diploma.
Yes, and then the other day the court said a higher diploma is equivalent to a degree.
Okay.
Court inasema vitu mingi na usikii. Yes, so yeah, it actually is. A higher diploma is equivalent to now a degree. So then now you can go past the job group.
In terms of job group. Okay, so tell us about your degree program. It's 4 years.
Yes, it's 4 years.
So first year, second year, what do you do? How does it start?
Yes, so...
Because I'll tell you in MBCHB, number 1, 3 years, mnapiga sciences, basic sciences. How about the...
So it will be similar, but above the sciences, because I believe sciences you're saying pathology, whatever those are things. And then in addition to that, we have like easy others, kadhalikas for suji communication,
suji
medical processes. Anthropology, some of these theories. Yeah, suji when a child is growing up, they love the father.
It's called behavioral science.
Yes, behavioral sciences and everything else. So yeah, that's I would say, according to the curriculum, is so much confined into the first year of when you're training for the degree. And then in the second year, there's something they call junior clerkship.
Also, you start clerkship in second year.
Yes, you start clerkship in second year. Yes. Then, so for that year, you do your junior clerkship, which is basically clinical stroke nursing, if that makes sense.
So you do sort of a nursing thing there, wound dressing.
You actually do wound dressing, bed making, admission processes, and vitu kama hizo. So inakwanga tu, and then it's also your kind of entry point. At that point, no one is even like uko theater, unaenda kufanya. Umetoka tu kusoma sijui what theory of change. Yeah, so anyway, so it is, so second year is junior clerkship if you're speaking about the balance between class and the ward. So that is at the point where you start seeing students coming into the wards. But because it's not very intense, you still have so many other units. I feel like in my beginnings, I used to have like 12 units in a semester. So in the beginning you have a lot of units, so that then in the future you have less theory work.
So you
yes. Then second year, third year you have intermediate clerkship. This is on top of now advanced pathology. Okay, not advanced. It's not called advanced. It's like pathology 2, pathology 3, something like that. All those they're like 4.
Then the fourth
there are like four major units: pathology, internal medicine,
surgery. Do you do surgery?
Yeah, we actually do surgery. So I think gynecology. So you actually now keep going higher, if I would say, with your how your units are planned out as you go forth. You can't. It's very difficult for you to start gynecology in first year. Yeah. So you find it most likely a third year. Then at that point,
so you're mostly in the wards or mostly in class? Or
by third year,
is it a 50-50?
Yeah, by third year, like where I went to school, you'll have alternating days. Today, like Mondays used to be class, Tuesday hospital. Wednesday, Evo.
Okay.
Yes. So that now that almost forms a balance. That's
so
by
in the words you clerk, you present.
Yes, in the words you clerk and you present. And I feel like in the second year we used to be in the words twice a week. Yes.
And then third year you alternate.
Yes, then third year you alternate. Then fourth year, by the time you're unafika fourth year, you're almost entirely in the ward because now you've done
unamaliza mambo ya theory.
And there's in your fourth year there's also, so it's now senior clerkship. It's now called senior clerkship at fourth year. And
that's the last year.
Yeah, that's not
so
the last year.
So you're mostly in the wards.
Yeah, now you're mostly in the wards. You have very little units. Maybe semester unapata mkono units ka 5 ama 4. So depending pia na speed ya ama curriculum ya hiyo shule yenyu.
So the schools that offer this, I know of Uzima and Kabrak.
Yeah, Uzima University, Kabrak University,
JKUAT has.
Yeah, Mount Kenya University. And then now there's just a mushrooming of so many colleges. Oh, there's KMTC, of course, for the diploma. Then there's a mushroom of a lot of institutions, including facility-based institutions that are offering
faith-based
diploma.
or facility-based.
Yeah.
Like a hospital with a training
hospital
program.
with a training. Yeah. So not all facility-based.
So let me ask. Now you have this diploma that has done 3 years and a degree that has done 4 years.
4 years, yeah.
Then now you both meet in the wards for internship. Internship is similar roles.
Has similar roles.
Is there a difference?
No. Yeah,
Because I have been I've supervised interns and I've not seen difference in the roles.
Yeah.
Or difference in the spectrum of training.
Yeah.
As opposed to, what you'd expect from a medical officer intern, because this one you're expecting them to be in theater, for example, if it's in surgery, to be doing CSS. What about now the CO intern degree? You even don't know the difference, but what from my point of view, what is the difference? Because the only difference I've seen probably is in I don't want to say. But you
the money?
You tell me what the difference
okay.
is.
Sawa. So there's a lot of difference. Hata logbook yao ni pages kidogo. Tuanze huko. Anyway, so they're really expected to do up to a certain point, then the degree will continue from that point to another point.
So what is this point? Okay. Let's go to a surgical ward. That's where I'm familiar, maybe. They
actually like so, when you look at the scope of service.
Yeah, patient has been admitted with a fracture.
Okay.
An open fracture.
So let me cool pause. Yes, cool pause on that question. So that I say this, when you look at the scheme of service for clinical officers, it will definitely start with diploma or history taking, clerking. Okay, that's history taking. And and patient management, follow up, and then organizing, training, supporting. These of it with teamwork. Now others come there, and then as you go forth into the degree and the master's levels now and the management, uko abedijo groups, GS, kwa director, clinical services at the county, you see those job descriptions that started in the beginning zinaenda tu zikiongezeka. Hakuna ati utafika huko director clinical service afai ku clerk. So yes, so we basically are supposed to do everything they do now plus a few other things.
What are these few other things?
So a patient has come in with an open fracture. In an ideal setting, we a diploma and a degree, a clinical officer, for that patient, they're supposed to do everything. Sawa tu.
This is an intern. At internship?
Yes. Yes.
So
I would say yes.
They're supposed to do everything in terms of clerking, admitting the patient. You
should be able to do everything. The only point where, I feel this is what makes a difference, and some facilities actually take it, but some others don't. Some facilities will give a little bit of bigger burden to the degree holders. Like, you guys will need to come for, I don't know, night shifts, or you guys will need to, there will be an added role to them. After all, hata wao wanalipo pesa mingi kuliko even at internship. But other facilities just don't. Mnaenda mnajipanga tu vile
mnataka.
Yeah. But even internally, as you organize your groups, you realize that you will tend to give the diploma holders less work. Yes. Yeah, but ideally, and I wish, of course, I can stand to explain this, that you see medicine is like sorcery. It's like witchcraft or something like that. The more you do it, the more you do it, the more you get better at it.
Yeah, experience.
Yes.
Wait,
and
what
the
do
more
you
you
mean? Lakini wewe mkamba. So sad.
No, like yeah, exactly. Wacha nikwambie, kama ni
mganga, the more you do
mganga,
witchcraft, the more you do, the better you get. Wewe unajuaje?
I mean,
Ushaikuwa mjanja.
Unajua kwetu ama niseme hapa should. Yeah,
so you get better with experience.
You get better with experience.
That's true.
So, and then you can only get as good as you want. There are degree holders that can actually do a CS without the help of a medical officer. And then there are others that don't even know the layers of the stomach.
Don't even know how to switch.
Yes.
But so the program does not push you to have to know.
You see even the scope of in fact, even when you're being sent for internship, or okay, tuachana na huko, when they give those circulars, when there's an approve, these are not doing this, so now they are going to theater, you realize they will give statements and they will say, you're allowed to do as per training and as per experience. So I would very, very clearly say that there is no clear cut or demarcation of this is how much you can do. So I think it takes me back to you can only get as good as you want. So of course there are always the operational or the institutional guidelines or like if I went to theater, doesn't matter how good I am in say for example in CSN, Caesarean sections, and I went alone, and this mother passed on kwa hiyo kitanda. Sasa hiyo kesi si ni juu yangu, because there's a medical officer, there's a consultant probably. So if you didn't think you need to go in there with a medical officer, sasa hiyo ole wako, you know. But
who regulates the practice of clinical officers?
The clinical officer council.
There's a clinical
officers council, yes.
If,
so it registers
for example,
and regulates.
what you're saying happened to you, would you face a disciplinary hearing under the clinical officers council, and what are the repercussions? Because I know if that happens to me as a medical officer,
yes.
if that happens, then my license could go. Yeah, because we're in the era of medical legal issues. My license could go. I have to, tear myself. What happens in your case?
So
because are you allowed, as you said, you've decided to go there alone? Are you allowed to? Does your scope allow you as a clinical officer to do a cesarean section?
Yes.
Alone.
Yes. So it
as
actually
a degree clinical officer.
As a degree clinical officer, the scope actually explicitly mentions that you can do minor surgical procedures.
Minor surgical procedures.
But that's the definition of minor. It doesn't put the list of these are kwa GUT hindo kwa
so is a CS considered a minor a minor procedure?
If it would, because
it is not.
Again, it depends. It depends. Because sasa 4 previous cars hiyo hata ilikuwa minor hata kama unataka. So and then CS I feel like it's not a very complicated procedure.
You might want to withdraw that statement.
No, it depends. I know it depends. There are two sides of this coin. But under normal circumstances, it shouldn't be. So
well, I don't know. I don't know about that because there are hospitals. Reputable hospitals. Okay. There are major hospitals in this country. Where is even however experienced you are as a medical officer, hata uko na 20 years experience, you're not a gynecologist or obstetrician, you're not going to operate even a fresh abdomen.
Nice. So yes, and that looks
unless
nice. And
it's a dire emergency and there is no one.
Yes, and that's why I think.
So I don't think a CS should be classed as a minor, because it is not.
Yes,
because of the sheer degree of complications that can happen.
That can occur. I mean, I have seen that. So again, I would say, just like I mentioned, I think it also depends with the organizational. The tenets they've put to guide.
So let's circle back to. I had asked about who regulates.
Who regulates. So clinical officers council does it
determine the scope of practice as well?
Because it does right from the training. It should register you at training and also follow you up to internship. It's the one that sends you out to
practice now.
Yes. Okay, it doesn't really send you out because there's the
they
MOH.
License you,
they license you.
So
they also
by licensing you, they're sending you out to practice.
True. Yes. So they also hold the rights to like terminating your service and everything. So even your employers and these medical legal issues, these are can actually be reported just directly to them, and they can follow that up. And then again, just like any other profession, as much as you're licensed, then of course the client has the right to sue and. So these repercussions can start right from the courts. Uko Kisumu kabla uletwe hata COC. Yes. So as a clinical officer, you're bound to practice within hizo
Is there like a clause that states that a clinical officer should practice maybe under a... Because for me, yes, if I'm a medical officer and I'm maybe doing a CS, ideally I should have somebody senior to whom I'm reporting.
Yeah.
If all goes south, if I go in to do this CS and I get a complication, I should be able to call my gynecologist who is on call and tell them, hey, nimelemewa, please come in. Yeah. Is there such in clinical medicine?
Yeah.
Ama ni wewe tu kikulemeni hivyo.
No, under the Kenyan law, there's an act of parliament, should be number 26 of 20, I think the last time was 2010 that it was revised. And so it actually states, I think it speaks about the entire clinical service structure. Yes. So it's even enlists what level should have what type of healthcare workers. And I think this is how we end up not having medical officers in dispensaries. Yes. So that the tiering of facilities actually informs that a clinical officer will work under a medical officer at this point. Yes. So you'll have facilities led by clinical officers, most likely up to level 4.
Level 4.
In some level
4s. My levels. But is it level 4 like sub-county, some county hospitals are level 4?
I believe I have seen a few that are led by clinical officers, but primarily, because, okay, I stand corrected. What's the level of, there's Vihiga County Referral, there's Tigoi. So it's called Tigoi.
That should be a dispensary.
It's not. It should be a health center.
What's a
center is the level 3.
Level 3.
Okay, that's a level 3. Okay, yeah. Because I actually I served there.
You worked there?
Yeah, I worked there.
As a clinical officer?
And it's actually led by a clinical officer. But I ideally, okay, we can all look at that clinical service schedule from Parliament because they make the law. Yes, but to answer your question, yes, there's actually law that describes who is to serve at what point and what are their roles. It actually dispenses what you can do and how you report to someone else. And this reminds me of a discussion I had with someone just earlier this week that even if I worked in an organization where there's a medical officer, with or without experience, that medical officer definitely becomes my supervisor. So some of these things we need to agree. Because it's actually...
There was a circular some time back. Somebody informs me that it was discounted by KMPDC. But there was a circular that came out on the roles of a clinical officer, and it was, what? Things that even senior medical officer shouldn't do. They were saying a clinical officer can do ORIFs, a clinical officer can do hysterectomies, and it was bizarre, and it created a lot of online wars on this now informs there's always this quote unquote that they say there are cadre wars.
Yes.
And the cadre wars are existing between clinical officers and the so-called medical officers.
Yeah.
And do you think there are cadre wars?
Yeah, cadre wars are everywhere, including in tea plantations. So we have cadre wars.
Tea plantations. the farmer versus the plucker.
Supervisor namba hata wewe unafaa utundizi majani tumalize haraka. So cadre wars.
But I think cadre wars would arise in a state where there is a gray areas in terms of what
clear areas.
Who should do what.
Yes.
And that is what I want us to demystify on Daktari A Quick One today.
Okay.
What is this area like? What can a clinical officer do? What can a clinical officer not do? Or what... Okay, can do is something else. Because, as you said, medicine is witchcraft. Well, I don't think it's like witchcraft. But there's an art to it.
It is an art.
I mean, you can teach someone to do something and they learn to do it. They do not have to have gone through the whole system for training. But are they supposed to?
My mind was wandering when you were talking, but me and you know of a clinical officer in Vihiga County who's almost a referral point. When you call the guy now, he's like, can you try and talk to this clinical officer? I think he's a CEO Obs guy.
I don't know him.
Lazima deny. But anyway,
I don't know.
I wanted to say I stand with COC. Whatever you said is right. So I believe when they're talking about a CEO can do an ORIF and everything, we have a line of specialization that clinical officers are now allowed to go into. And actually, most of these now have a master's in clinical medicine in child health.
And how long does that take?
How long does masters take? 2 years? Should be 2 or 3. I've not done any masters in clinical medicine, so yes. Might be 2. Who knows? 1 year hizo material, and then 1 year you go doing your or your
because
research.
I know higher diplomas are 1 year. Yes, higher diploma they rotate in the department for 1 year.
Oh, they rotate for 1 year, but I believe they also go to class for another 1 year.
I don't think they do.
They should. they should.
Just find out. But I think it's 1 year start and that's it. And then
1 year ukitoa public holidays umefanya nini?
That is the question, because
it should be 2 years.
I think it's 1 year.
It actually should equate to an upgrader. It should equate to an upgrading student.
Upgrading student.
But you know of diploma students who go for bachelors, and instead of taking the 4 years, you take should be 3 years ama ni 2.5 kitu kama hiyo. Yeah, you just do an upgrading. Okay. Anyway, so I need to check. I've also not been interested in doing a higher diploma, so I've not checked.
You wouldn't do a higher diploma. You would do a master's.
No, but I would if maybe I wanted to do ENT.
Or you can do a higher diploma. It's like another degree. Yeah. So it's like now another degree.
Yeah.
Now you see, this is the bone of contention. This is where we now bring in the Cadre wars.
Yeah.
Because in my definition of what a clinical officer is, in my definition is that this is a person who should be in a clinic, because from the word clinic. So mostly they should be in an outpatient setup. Clinic, clinical officer. But then you find that somebody goes and does a higher diploma in gynecology. And maybe they have the experience. And this is 1 year. And now they are in this purportedly in the same level of clinical experience as an obstetrician gynecologist. This is someone who pigad is 6 good years, and maybe I'll repeat kidogo pale in undergrad.
Wakagoma pale Moi.
Wakagoma mazee akapiga miaka yake 9 proper. In undergrad. Okay. When you talk about you doing your sciences in a year, this person did their basic sciences, just in theory too. Unaambiwa tu mazee, disease can like this is normal. Normal for 2 years, then uanze pathology whole year. Anatomy, dissection peke yake, you have to dissect the whole body. Now it's 2 years, otherwise it used to be 1 year. It was crazy. The whole year, because all your thing is anatomy lab. Alafu sasa urudi masters. Miaka yako 4.
Masters is 4 years.
Uko sure? Yeah, and this is like one of the shortest. You see where the Cadre was come? Because
it's 4 years.
It's 4 years.
Masters in medicine.
Like it's for general surgery and orthopedics, all that. It's 5 years. For neurosurgery, it's 6 years. It's actually 7. For peds,
that's the masters alone.
That's the masters after you finished your 6. For peds and all these other things, it takes you a good 4 years. And even IMED, and these are considered the easier ones.
Okay.
So you figure your research, you figure your forget. Let's take the part of a gynecologist. Ule alienda amemaliza 3 years in diploma.
Well, I've always assumed it's 2 or 3.
Oh my god.
Okay.
2 years hata ujaanza ku scratch the surface.
Okay.
2 years, 3 years amefanya nini yake? Inaitwaje? Diploma. Ameenda internship yake mwaka moja, ameingia shule. Amefanya 1 year higher diploma. You expect this person to be at the same level as a gynecologist who has done now 4 years of masters on top of the 6 that were undergrad, total of 10. These are other persons that done total of 4 years. So you get where the Cadre was come. So when the circular comes out and says that this person can do an ORIF, which now that's ORIF is worse because orthopedic amepiga miaka 5. Unaona?
I
They've
know.
done 5 years.
I know. This surgeon would say, I know you know him. You worked with him in Vihiga. Like, daktari wajinga sana. Anyway, so I know.
So
I know
you
that
get
brings,
the point of the cadre was.
definitely.
And the
They
cadre
didn't
was
start from somewhere.
The cadre was has always been put is such that maybe medical officers or doctors look down upon clinical officers.
Yeah.
That's the notion out there. But I think it's just a matter of what should a clinical officer be able to do.
Yeah. So let me say the career or this whatever of a clinician subset of clinicians was introduced as a gear towards helping primary health to augment primary health and mambo kama hayo. So I want to sensitively say that these advancements and everything else have just come as a result of need to fill in or the need to and
Because there are shortages, you mean?
we definitely have a lot.
we do have shortages.
Yeah, so I think fill in and now this one is very sensitive but about the cost of hiring. So it feels like you would hire a little bit more of specialized ENT clinical officers more than you would hire ENT medical officers.
Surgeon.
Kitu kama hiyo. Even if it's just for the consultation part.
Yeah, and so, but let me ask you, if you have your child, are you a father? Are you a dad? Not yet, wow, for example. But for example, you have your child. and your child has tonsils, tonsillitis, or, that now require a tonsillectomy. And you have a clinical officer in ENT and an ENT surgeon. Yeah, this one is offering to do the surgery for you at 30,000. This other one is telling you 200,000.
Yeah.
Utapelekea mgani?
That question, like Reverend Victor, I'll let you to ask God. But I think let me not answer that question directly. But I think I want to go
personally as you. Because we're about to take a break.
I think it depends with the capacity at that point. Being that this is the last thing before we go for a break.
You're being politically correct.
I'm being politically correct. I don't want to say because it also depends with where you can afford. Tuseme tu kweli. Like today, let me just say, if I wanted to go for a change of my specs today, I would go to say Avenue Hospital or Aga Khan.
Because you can afford. Because you got the money.
Yes, because at least you can go and run an insurance cutting that
Daktari,
one.
you know, what you're saying is very dangerous.
Because of what?
Because you're saying that...
I wouldn't go to Optica. That's what I'm saying.
You're going to go to Optica?
Yes.
Optica is cheap. I don't know about
definitely. Consultation Optica ni thao. Wapi sijui ni 4K. Ujaongea na huyo mtu. Shakula 4K. Yes. So and then their frames will be like 25K, 20, whatever. Optica
do you think the level of care will be the same?
When you're talking about the tonsillectomy, I think it still goes back to how well do you want to get in your craft. Honestly speaking, I know of bogus medical officers. This one I would say. I know of clinical officers you go and unasema vitu zako and they will just misdiagnose you. I know of them. Me and you know. Tuambiane tu kweli. Hata kama tunatetea pali tunatoka. But yes, I equally know of bogus, very, very bogus clinical officers. And I know of very, very good clinical officers again. Yeah. And I also know very, very, very good medical officers. You just call like this, you're consulting and they serve you pap. They're actually medical officers I could not consult myself.
You're like, I'm better than this.
I'm like, by the way, so I want to still say you only get as good as you want. Hata wewe unajua when the actually medical officers, even interns, will be like sidelining towards like, hayuko duty this week, but wacha tu tumcall. Yes. So even for medical officers, it feels like you only get as far as you want. As good as you want.
On that very good parting shot, let's take a short break.
Yeah.
Daktari A Quick One. We'll be right back after the short break. Daktari A Quick One, welcome back. Yeah, so we are with Daniel Mumo here. and we are fighting like the cadre was though off camera tumesema that it is wrong for us to categorize human beings and say that people who are maybe not as financially able should go to certain facilities or certain cadres who might not be, as might not offer the same level of service. And we're saying that the government is at fault at this because of looking for cheaper labor.
No. Actually, one thing is that there's also, we say referral is management.
It's part of treatment. Yes.
Yeah, it's part of
one
management.
of the most important.
Yes.
Parts of
So,
treatment.
and that's why we have referral pathways,
Structures,
and also the government should actually continue to invest deeply into the capacity of referring, because some of these are ambulances and the rest of those things. Yes, and I believe that's why healthcare is structured in such a way so that as a diploma clinical officer, you have your CHVs and everyone at the dispensary, say for example, or in fact some dispensary only have nurses. Now that's another discussion. Yes, so some dispensaries actually have just nurses, and then you go up to health center. Yes, level 3. No.
There's level 1, 2, 3.
Yes. So level 3, and at level 3, you most likely will meet with a clinical officer. At level 4, again, a clinical officer and maybe a medical officer, depending with the county where you are in. There are some that have a number of medical officers, so level 4 are now.
Some have one.
Some have 1, some have 0. Actually, most of them have theaters for the maternity, sana. Level 4. Then level 5, now you even have consultants, hapo hivyo. So it is very important, and this goes out to every healthcare worker, including myself, that you need to get well in your craft. You need to get so well in your craft.
I wanted to give a comment on that about getting well in your craft. There's something you said that logbook diploma clinical officer ni pages 3.
Of course ni kadogo kuliko.
I get the point. But the training, what I found during my training as a medical officer is that you have no option but to get better. At the least, even that very bogus medical officer will know something. They might not be very bogus, but the system is structured in a way that by the time you exit, you have a bare minimum.
Yeah, that's just about.
Yeah, so it shouldn't be up to, we're not students. As a student, you're young, you want to be sneaky, they'll do that. But there should be, the system, the structure of the training should be in a way that bare minimum lazima ufike. Tuko naita 50 plus 1 in medical school. If you don't get that, you're repeating. You're being discontinued. You're being discontinued if you're doing that. And internship, you can always redo the whole internship.
And I think that also applies to even to clinical medicine, because our supervisors are medical officers when we come there, and so I feel like if there are any stringent measures that should be applied.
Let me speak on behalf of medical officers and consultants who are charged with supervising clinical officers, and I've heard this from even other consuls.
Yes,
we don't know how to train you. We do not know. It is way much easier for me to deal with a medical officer intern. And also I can speak for my consultants. It is much easier because they've been through that structure. They have been through that system. They know what was done to them as interns. But now you're bringing somebody who's had a different type of training than you. This is as a train when you train, but and I expect you now train them. As you said, experience is good. I mean, if you deal with clinical officers long enough, you might know how to deal with them. But if you've not had that exposure for a long time, then it is hard to ask a medical officer or a consultant to actually supervise a clinical officer. because you're like, okay, is this too much for them? Is this too little? Yeah. So and then now there's the confusion about degrees and diplomas.
Yeah.
Because as I said earlier, there's a difference that we can observe as supervisors, and you can see it like hata kama ujui, when you start interacting with a group of clinical officers, you'll always see there's one who is standing out in terms of their knowledge, in terms of their confidence.
Yes.
And then there's others who, they are maybe taking a bit of more time to get there even from the beginning.
Yes.
And if you ask, one is a degree, one is a diploma. Yes. You're like, oh, probably that's it. So for us, there's a bit of confusion. We really don't know how to train.
Yes.
And one of my consultants put it very clearly. Me, I don't know how to train them. So I will just sign their logbook, whatever they bring. But for a medical officer intern, they will try as much, and because they know what they
actually remember just what they did not the other day. And what I would say about that is, yes, maybe we would say we need anyone who's supposed to supervise to maybe understand what a clinical officer should do, and you realize you are kind of also the supervisors to the nurses, because they will not just be doing anything now. As a medical officer, you'll be like,
no, but you're not supervising nurses. You're not training nurses per se.
You don't train.
Nurses have their own. They're being trained by other nurses.
By senior nurses.
You're giving them instructions.
Yeah. Yes, but you actually will oversee in one way or the other. The consultant will be like, you mean this one was addressed this morning? Like, Ebu called me the interns, the nurse interns. Yes. So I feel like I would put it out there that yes, it's important for organizations or institutions to look at how best these supervisors can understand what to actually do. This also goes out to senior clinical officers in these institutions. There's always clinical officer in charge, I believe, in these facilities where people are interning. So I think it's also their role to ensure that my people are doing the right thing. But again, it goes down to, even for medical officers, even for consultants, for everyone, it goes down to, it is very, very personal effort. See, that hypothetical, what is it called? Hippocratic. Hypothetical is about research. Hippocratic act, the oath. When you say it towards the end, mine said, if I do these things, I shall forever be remembered, and if I do not, shall I be forgotten, and kuna vitu kama hizo. So it is very, very personal, how you serve your clients, how good you get to be with them, and vitu kama hizo. So Cadre awards will be there. And then the discussion about how do we do what do we do is like starting to talk about corruption in Kenya. What do we do about corruption? We can have like even summits, even Africa summits about corruption in Kenya. But you see, corruption starts from even kudanganya mtoto wako na sweetie, rudi ukuvae viatu ukuje. Yes, so wewe ulishaenda. So I'm not saying that's corruption. That's just parenting.
It is corruption.
But so it starts from very, very minute things, even in the community setting, and it goes all the way up. So there is no one way that fits all. So I think that's a discussion that will go on and go on and on. But as professionals, there's the intersectionality of where we meet, and I think one should just continuously get better. I have worked with the medical officer consultants, and who've been so lenient. I mean, graciously lenient, and you're just like, okay, you are different. Yes, and I feel like I should just mention Dr. Betty Shiruli. That's like an internal medicine consultant that I have never met in my entire life. Under that one, you just become the best clinical officer you want to become. If you want to become a stupid one, you will, because again, she never rushes after you, but you will just keep repeating. I mean, she's just good at what she does, you see. And this is just one example. You cannot forget Dr. Koba and Dr. Morino Kango, for example. These are people who've actually just mentored me during my internship. So these are consultants who have nothing to do with where any clinical officer. You need to know this one. This one
you
is
have to know.
Bare minimum. It is in the protocols. So this also goes out to the clinical officers. That I think kuna tu vitu lazima ujue, we can't be having a kid in the ward with solid limbs nini na wewe hata hujafanya UECs, for example, na unaona tu kila kitu ina point towards a certain diagnosis. So I think it goes to personal work.
What I'll say about what you just mentioned here, Mwisho, and shout out to all your supervisors. You umesema ya mwisho about not, having the right diagnosis or not doing this. It is not wrong not to know. You're allowed not to know. I mean, it's That's experience. True. You grow in the profession as you learn, but always consult.
Yes.
I mean, there's always someone senior. And this I think, as we are now in the spirit of advising clinical officers and other junior medical officers. And I will say this on my TikTok sometime.
Okay.
Consult.
Yes.
Kama ujui, refer. Kama if you're not sure, consult, refer. Yeah. Because we can avoid, because my Cadre war started when I found people, clinical officers, say, missing cancers, because I'm usually a champion of cancer. Missing cancers, debriding wounds, debriding cancers, wounds unaddressed for years and years and years and years, treating, gastric CA as H. pylori and gastritis for years and years.
Yes.
And the patient still comes and they still do the same thing. I think that is unacceptable. Like, if something has not worked, there's always there's always somebody who knows better. And in medicine, Dr. Ariel was saying the other day, in the US, there is a specialist, like ENT, for example, specializing just in the left ear alone. So you can there's always somebody senior.
Someone senior to refer to, yes.
It's not wrong not to know. It is not a crime not to refer.
Yes.
Always do it.
Yes.
Try. If you don't know, try. So
I think that sounds like a solution towards because one of the ways of getting better is accepting you can be the least knowledgeable in a room.
Yes, exactly. And that's okay. No matter how knowledgeable you are. That's true.
Yeah.
Now we have these. I think even in your explanation, we've seen some gaps, like in terms of clinical officer degree, clinical officer diploma. Where the line is drawn on who should do what.
Yes.
Okay. What do you think is the future of this noble profession that has been there for years and years? I think we started training clinical officers in Kenya before we started training medical officers.
Yeah, that should be true.
Initially, let me just say, initially the idea, what I think, what I have seen, read, I wasn't there, but initially the idea was to have clinical officers as physician assistants.
Yes.
Which is also the case in some other countries. Physician assistant. So you work under a physician.
Yes.
Not allowed to see patients on your own. Something of the sort. What do you think for our country where we have shortages, where we still need clinical officers in primary healthcare? What do you think is a permanent solution or a future for this? We
will all agree that with or without the Cadre wars and the confusion in the air, we are moving somehow. We are crawling, we are hoping, but we are moving. So I believe we have somewhere we can start building from. And this goes to say that whatever we have, forgetting about the past, I think whatever we have is to work to streamlining it, to ensure that there is clarity right from training, that you can better and pursue clinical medicine, and this is what I will do as I head pale mbele. So I feel like that is something that can be done by our governing bodies, including the Department of Health under the Ministry of Health, just to come together to know, because I know the Permanent Secretary for Health is actually supposed to be somewhere about the training of all professions. So there is actually a department on training under the Ministry of Health. So this is something that can start from up there, because they definitely know that this affects performance somewhere. And right to us as professionals, the interoperability of the professions we cannot demean it. And we cannot forget that at some point we really applaud what a clinical officer did. Yes, and there's just somewhere they did so well. And even if we start looking at the health system right now, they are a sustainer of a very huge ecosystem kwa hii healthcare system ya Kenya. And so I feel like we just need to move a step forward rather than keep timing at where we are, so that from training to posting to what you do in the wards and everything else, you actually know what to do. And I feel like, again, as clinical
your
officers,
pathway should be clear.
It should be clear.
You should know.
Yes.
This is the scope.
Yes. And then this also for people right now, we also have an impending crisis, or if not a crisis actually, with nurses. We have, I don't know, CNA, KRCH, I don't know what, diploma, degree, and there are like 5 cadres. You are confused.
Yeah.
Yes. You go to referral hospitals and you're being served by a nurse patient aid. Who goes to school for like 6 months. And the county is actually hiring these people.
Not even counties, even some private hospitals.
I
remember there was a time I worked for a private hospital, and I was doing a ward round with I thought she was
patient
a nurse.
assistant.
I thought she was
patient
a nurse.
aid.
I was very young in the profession. I didn't know. So, and then I'm like, hey, this nurse, have you taken vitals? No. What's the BP? She died? No. And then I chased her. I was so pissed because I'm having to zero graze. I'm having to, go take BPs myself. I told her, if you're not helpful, just let me do the round on my own. Then later on, I found, she was actually a nurse aide.
A nurse aide.
And not a nurse.
Okay. So, So if it's not a crisis, it's actually an impending crisis. So they need to also, because you are the regulators of employers, like you can actually say that we only allow this to this extent, and you can actually follow up.
I think when you're saying the regulation is where the problem is, because you mentioned something about mushrooming of schools and clinical officers, even institution-based trainings. And I think that is an issue because people are out there for the money. I mean, I just train these people. True. I don't care where they go to work. As long as they've paid me their 90,000 for training of a CNO, if she gets employed as a nurse, hiyo ni bahati yake. Mimi memtrain kama nurse aide. I mean, clinical officers, start a degree here, start a degree, another degree there, create a master's. You don't know what these people are going to do. Where as long as they're paying you. And I think regulation is important.
But still, again, even for a CNA, for a certified nursing whatever aid, it still goes, I will still zero into try and be better, because I know they still go to hospital for like 6 months, 3 months, mi sijui 2 months. Ni fupi. Ukitoa holidays nakwanga tu kwa ukitoa holidays ukitoa holidays hapo baki na siku 8. So even in that short period that you go there, you try and be useful and try and match whatever if they taught you and what is on the ground, so that even when you're left with that patient at home, because most of them now serve patients at home-based care, you at least you know what to do. Again, it goes back to like consulting. You definitely have a nurse, you have a clinical officer, a medical officer in your in that kwa hiyo patient wenyu. So try and find a way of ensuring you can always ask
at a personal level. This now boils down to as an individual.
By the way, wacha nikwambie, I come from Kwale, that's home.
You do. Stories
are told of a place called Lungalunga, pali kuna kwanga na mashindano ya waganga. So
competition ya waganga, ama mashindano ya kudungwa
waganga, like we go stand there, like mganga mmoja ana command muti na kauka immediately na kwa kuni mwingine. So I'm just saying you can only get as good as you want, you know. How much that one mganga is sacrificing to their gods helps them get better the next competition, you know. Yes, so we also need to individually do that. That one, I believe, I would say it's my mantra or something like that. And if I think you want to ask me, the last thing you want to ask me is what I'm about to say about clinical medicine is we don't need to line up all of us to work in a hospital.
Hallelujah.
Speaks in tongues.
And but we can. I mean, the hospital space is also very big.
It's also, very big.
Because I like what one of my people, somewhere I locum, I like what they do with clinical officers. Yes. Medical officers are there, they see patients, they deal everything with patients. But when it comes to insurance things, when it comes to, they call it
care management.
Yeah, something of the sort. And they're very instrumental in writing medical reports to insurance companies, following up in terms of has this patient been discharged, has they paid their because they understand the clinical knowledge a bit. But this person does not want them to actually see patients because they know there is a bit of a gap between them and what the medical officer can do. But they're making very use of them. Yes. They've employed very many.
Yes.
Yeah. So let's not all
I'm saying I personally wouldn't even want to work in a clinic like forever.
Yeah.
So and that's why I'm saying this, because I think we go into these classes, we go into these schools thinking that nikitoka hapa well calculated moves nitaemploy na hii county ni kama Embu wanalipa 50,000 gross. Anyway, wacha nisikasirike hapa. But what I'm saying is we have so many other spaces, including the NGO space. Now we have climate change that's affecting, including, I don't know, it's even affecting gender-based violence, and these are interesting spaces that you have a scientific background, and so you can actually take on a way that's kind of unique. Now we say, this is what I want to go and do, and then you go and do that. So you can go into research, you can go into, there's so many other areas, into community management, into enterprise management, because all these facilities are managed by people and they need a clinician. If you go
nowadays, insurance companies are employing clinical officers.
Yes, because you need to make a call knowing what an endoscopy is.
Those who are there, kazi ni kureject too. They're always rejecting our claims.
I'm here to support you guys.
No, you actually make the patient's life hard.
Yeah, that's right. No, but of course, you guys do your work.
Their work is actually, I was told that they are graded, or you're deemed to have performed well, depending on the number of rejections you have. The more you reject successfully, the better you are.
Okay. But companies are also trying to hold their money. Like our pool is almost ending. So anyway, that is about insurance. I've not worked there, so I don't know. But I know.
But I like what you said. Yes. Like we don't have to all crowd onto patients, because now medical officers wanna grow. They are becoming more because there are more medical schools, more people are being trained, and now the spaces are becoming too competitive.
So. And that goes out even to medical officers. I have worked with.
You don't also, as a medical officer, you don't have
to. Kwa line unaenda hadi loka 1500 unafanya.
Inauma aibu.
So because I know the average rate in Nairobi is like 7,000, but I know facilities that will still hire medical and pay them like 1,000,
and they will go because of desperation.
Because yes, I think I'm not saying
pride bana.
And also an open-mindedness of some sort, because you don't need to be a doctor if you're working in a hospital. Like me, I go to outreaches naenda na other peers when you have been in heroin use before, and we go out and reach out to these people. That doesn't change that I am a clinical officer. So I still serve as a clinical officer, but in a different scope. So we don't only need to fit into Mbagathi hospital. So I
will take that as your parting shot.
Thank you so much.
Do you want unataka kusalimia nani?
Wachana na hizo stories za salamu. But thank you so much. It's been impactful.
I hope so. For those who might have caught offense by basically what I've said.
Exactly. I'm actually offended.
Poleni, it's just an opinion. Okay? I mean, I have friends like this guy. Very good friend, clinical officer. We love you. Kina Calvo. I have friends and I have... No, Calvo. A very good friend of mine for a long time.
I'm not sure.
And he's a clinical officer. Refers so many patients to me.
But I thank God that you've umejishikilia. You never said that you supervised me in internship up to this point. But anyway, I have to tell you guys.
Anyway, Daktari A Quick One. Like, subscribe. Please, your comments. We want solutions to these things. We don't want to be in a country or in a setup of working where mtu anaangalia mwingine huyu naye. Yeah, because I've had even situations where a doctor calls me and kuna relative wangu anakuja hapo casualty, please enda nione, sitaki ongea na clinical officer. And it
casualty squeeze mkona
in other areas, in other places. And I don't want that to be the case, because we need to streamline these things. A patient needs to know that if I go to a hospital, whoever is seeing me is well qualified to see me and can do that job, and if they can't, they are able to look for better solutions.
But we can never give a solution to the patient's bias. How now? Mtoto wangu ni wa Cefixim.
How nilisema
Shika Cefixim.
It's a no. Anyway, Daktari A Quick One discussion for another day. Adios, we can talk forever. Like, comment, subscribe, share.
Thank you so much, Daktari.
See you next time.